development and its disorders. The development of normal male and female genital organ and tracts is determined by several factors, all of which are time specific during the embryogenesis. In the fifth week of intrauterine life, the undifferentiated gonads contain cortex and medulla. The critical period for gonadal development is at 6 to 7 weeks of embryogenesis, when Y chromosome promotes male gonadal development. External genital organs start developing at the 10th week, reach completion by the 16th week. Genetic sex is determined at fertilization, but the gonads remain undifferentiated until 6 weeks of intrauterine life. First, the sex chromosome determine whether the undifferentiated gonad urogenital ridge will differentiate into a testis or ovary. Y chromosome develops a male gonad, and absence of Y and presence of X chromosome develop ovaries. If gonad is male, genes associated with the Y chromosome interact with other components of the somatic cells in the primitive gonad and initiate development along the male lines. Elaboration of HY region complex in the short arm of Y chromosome, known as SRY, induces testicular development. Sertoli cells in the developing testis produce Mullerian inhibiting substance that causes regression of the Mullerian paramesonephric ducts. In the absence of MIS, the Mullerian ducts develop passively to form fallopian tube, uterus, and upper vagina. Female internal and external genitalia develop partially without the need of ovarian hormones and differentiate even in the absence of gonad, unless interrupted by the regressive influence of MIS. Gonads. The formation of testes occurs in the presence of Y chromosome, 46XY. Formation of ovary occurs in the absence of Y chromosome and in the presence of second X chromosome. XX chromosome are required for ovarian development. One X chromosome causes ovarian dysgenesis or Turner syndrome. Development of gonads begin between 6 to 7 weeks of gestation. At first, the germ cells appear, followed by the Sertoli cells that secrete Mullerian inhibiting factor and prevent the development of female genital tract. Sertoli cells also secrete testosterone binding protein that binds to testosterone. As a result, testosterone concentration in the testis is higher than in the serum, and this is necessary for spermatogenesis from primitive germ cells. A week later, in the 8th week, Leydig cells start secreting testosterone under the influence of human chorionic gonadotropin HCG, which has LH-like activity, and develop accessory organs like Wolffian duct. Peripheral conversion of testosterone to dihydrotestosterone is responsible for male external genitalia or the male phenotype. Genital tubercle enlarges to form penis by the 20th week. Ovarian determinants are: unless SRY is expressed, ovarian development ensues in the presence of XX karyotype. Internal genitalia. Wolffian ducts under the influence of testosterone form epididymis, vas deferens, seminal vesicles, the male internal genital organs. MIS from the Sertoli cells suppresses the development of female internal genitalia from the Mullerian ducts. Mullerian ducts in the absence of MIS form fallopian tube, uterus, upper vagina. Mullerian and Wolffian development begins at the same period of embryogenesis. These are the local phenomena occurring ipsilaterally depending on the presence or absence of testosterone and MIS. External genitalia. Dihydrotestosterone determines the development of male external genitalia. It is produced in adequate amount from 7 to 8 weeks of gestation till term. HCG stimulates Leydig cells of fetal testis to produce increasing amount of testosterone, which develops male organs such as vas deferens, epididymis, seminal vesicles. Feminization of the external genitalia is completed by 14 weeks of gestation, whereas masculinization is completed by 16 weeks gestation. Descent of testis is mediated by testosterone, insulin-like 3 ligand, and its receptor. Masculinization of cloaca occurs only if the testosterone is converted via 5-alpha reductase to DHT. In the absence of this enzyme, Wolffian duct system develops normally, but the external genitalia will be of female phenotype. Similarly, exposure to androgen in utero causes masculinization of external genitalia in the female, but the Mullerian system develops normally. Classification of the intersex disorders. Female pseudohermaphroditism include androgenital syndrome, 21 alpha hydroxylase deficiency, 11 beta hydroxylase deficiency, treatment of mother with progestogens and androgens, ovarian virilization tumor, male pseudohermaphroditism, primary gonadal defect, testicular regression syndrome, Leydig cell agenesis, defective HCG luteinizing hormone receptor, deficiency in testosterone synthesis like 17 alpha hydroxylase deficiency, 3 beta hydroxylase deficiency, 2022 desmolase deficiency, male pseudohermaphroditism due to testosterone insufficiency only, and organ defect like disorders and disordered androgen action, androgen insensitivity syndrome or testicular feminization, incomplete androgen sensitivity syndrome or Refstein syndrome, disorders of testosterone metabolism like 5 alpha reductase deficiency. Gender identity disorder associated with abnormal sex chromosome include Klinefelter syndrome, Turner syndrome, XX male, pure gonadal dysgenesis. Sexual ambiguity is frequent in mixed gonadal dysgenesis, true hermaphroditism. Factors influencing the designation of sex. Genetic sex. In each individual, the nucleus of humans contain diploid number of chromosome, 22 pairs of autosome, 1 pair of sex chromosome, making a total 46 chromosomes. During maturation, a reduction division result in each ovum and spermatozoon containing only haploid set of 22 unpaired autosomes, 1 sex chromosome. In the ova, sex is always X, but in the sperm, it is X or Y. The relative number of XY carrying spermatozoa is equal. Fertilization results in a 46 chromosome pattern carrying either XX or XY, genetic female and a genetic male respectively. Genetic sex of an individual is determined at the fertilization. External anatomical sex. The shape of the body, contour, the development of the musculature, the characteristic of bones, distribution of hair on the face and the body, breast development, and the external genitalia are strong presumptive evidence of either sex, individualized to either male or female sex. Internal anatomical sex. The presence of recognizable uterus, fallopian tube, and ovaries is the evidence that the individual is female. The rare exception is a true hermaphrodite, in which both ovaries and testes are found. Gonadal sex. It depends on the histological appearance of the gonad from the study of the biopsy or the removal of the organs. It is not entirely diagnostic, as in case of ovotestis, in which both male and female elements are histologically demonstrated. Hormonal influences. In a female pseudohermaphrodite, an excess production of androgen hormone by the adrenal cortical hypoplasia can modify the external genitalia of a genetic female. Hypertrophy of phallus, fusion of labia majora may cause the parents to consider the child as male. The virilizing tumors of the ovary, such as erinoblastoma, can cause hirsutism, hypertrophy of clitoris, deepening of the voice, masculine body contour, and amenorrhea. The presence of estrogen in the male can cause gynecomastia. These are all examples of how hormones, naturally or exogenous, can modify sexual organs and secondary sexual characteristics. Psychological sex. Many men and women are psychologically dominated towards sexual inversion, a persistence of the childhood tendency. Behavior, speech, dress, sexual inclination proclaim this fact. Transvestism, effeminate behavior are the most obvious and complete examples where men dress in women's clothes and assume the gender role, and vice versa. Environment and upbringing. They decide the sex of the rearing. There are many examples of genetic male and female reared by their parents in the mistaken sexual category and who have acquired over the years the habits and mental inclination of the opposite sex to a sufficient degree to pass off as members of the opposite sex. Clinical diagnosis of sex. Some abnormalities are seen at birth, but most are discovered at puberty. A man is broad-shouldered. He is more hirsutized, especially about the face and chin. His scalp hair is coarser. His nature is more aggressive, robust. His voice is deep. His sexual instinct inclined to heterosexual. A woman has narrow shoulders, broad hips, is rarely hirsute, has fine abundant scalp hair, more delicately modeled features, and a typical pattern of pubic hair, triangular, with apex downwards, flat base at upper level of mons. Her voice is softer, her nature is supposed to be less self-exertive, aggressive than male, and her sexual instincts are heterosexual. A well-developed breast is probably the strongest external evidence of femininity. External genitalia. In male, the phallus is well developed from genital tubercle. Urethra opens in the glans by 12th week. Scrotum is rugose because of the presence of dartus muscle, and almost exclusively male possession, and the testicle are in the scrotum. In the female, phallus is rudimentary and the urethra opens into vestibule. The labia majora are smooth, bifid, and do not possess the dartus muscle, and the vagina is present. Internal genitalia. Bimanual examination discloses the presence of uterus and appendages in the female. Signs of feminism in the male. External appearance has a feminine figure, poor musculature, a tendency to obesity, high pitched voice, absence of hirsutism, feminine personality, sexual inclination, and gynecomastia. External genitalia. Hypospadias, urethra opening below the phallus, under development of phallus, a split scrotum, and undescended testis are all signs of feminism in the male. Clinical examples are intersex is classified as chromosomal abnormalities, gonadal abnormalities, masculinization of female, partial or incomplete masculinization in the male. Disorders of female sexual differentiation, Swyer syndrome. This syndrome is a male pseudohermaphrodite, a pure 46XY gonadal dysgenesis with the presence of uterus and the cervix, but with hypoestrogenism, poorly developed breasts. Undeveloped testes do not secrete testosterone and male Mullerian inhibiting factor, resulting in the development of female genital organs and female phenotype. The woman presents with primary amenorrhea, absence of secondary sexual characters, female external genitalia, cyclical estrogen and progesterone can induce menstruation. Conception with IVF using donor eggs is a possibility. The gonads have 30% risk to develop malignancy and should be removed. Turner syndrome. Incidence of Turner syndrome is 1:2000, 1:5000 born live girls. About 70 to 90% of pregnancies with XO chromosome about early weeks of gestation. In this syndrome, either short arm of X chromosome is deleted or the nucleus possesses only 45 chromosome, i.e. 22 pairs of autosome plus 6 chromosome XO. The absence of Y chromosome resembles the female, but these patients, like males, chromatin negative. Their nuclei contain no nuclear satellite body and no drumsticks in the neutrophils. It should be explained here that the presence of bar body is dependent on the presence of second X chromosome, and if the chromosome pattern is XXX or XXXY, extra X complement renders the eccentric chromatin nodule either larger in size or in number. Turner syndrome has been called ovarian agenesis or gonadal dysgenesis because at laparotomy the gonad is found to consist of undifferentiated stroma with absence of sex cells, a mere pale strip of fibrous tissue attached to the back of the broad ligament, the so-called streak gonad. The follicles grow up to 20th week of fetal life but become atretic due to absence of one sex chromosome. In some, germ cell fails to migrate to the genital ridge from the yolk sac. These ovaries do not contain Graafian follicles, so estrogen is not produced. The patients are clinically of short stature. Trunk is muscular, neck is short and webbed, cubitus valgus is notable. Breasts are not developed. Pubic and axillary hair are scanty or absent. Exaggerated epicanthic fold may be present, one of the obvious defects first noticeable on examining the patient. The vagina, uterus are present but underdeveloped. Other gross congenital anomalies are present such as coarctation of aorta. Deformities of the digits are also seen. Other stigma include shield chest, high palate, low set ears, lymphedema of extremities at birth, and deafness. Stigma is due to chromosomal deficiency in the short arm of X chromosome and is not always present. Percentage of stigma depends on the percentage of abnormal X chromosome. Classic case of Turner has XO pattern, however, it may be mosaic of XO and XX or even XOXY, which produce less clear-cut syndrome. When a young girl with Turner's present with primary amenorrhea and serum FSH level is above 40 milli-international unit per ml, estrogen is below 25 picogram per ml, estrogen therapy with intermittent progesterone is advised to prevent osteoporosis. Artificial vagina may be needed at later date for sexual function. Administration of growth hormone 0.05 mg daily for 5 years near puberty will improve the height. Pregnancy can occur with donor egg in IVF program if the uterus is present. Few follicles persist after puberty, menstruation, and pregnancy is possible. Superfemale or the triple X chromosome. The presence of an extra X is not uncommon because it is quite compatible with complete feminine normality. There is, however, well recognized triple X syndrome in which the patient, who is often mentally subnormal, suffers from scanty or irregular menstruation and infertility. Clinical examination may reveal hypoplasia of the genital tract. Male pseudohermaphrodite. Testicular feminizing syndrome is now designated as either complete androgen insensitivity syndrome or partial androgen insensitivity syndrome. Incidence is 1 is to 2000 to 1 is to 60,000. Etiology. The peripheral receptors for testosterone are absent or are scanty or they fail to respond to testosterone. The external genitalia or a female phenotype chromosome is XY and the testes are located along its line of descent in the abdominal cavity or in the inguinal canal and are maldeveloped. The fallopian duct fails to develop because of the absence of testosterone receptors. Testis produces Mullerian inhibiting factor, so the Mullerian system fails to develop. However, the lower portion of vagina derived from the sinovaginal bulb appears as a dimple of 1 to 2 cm length. There is often a strong familial tendency to this disorder, and several cases may appear in the same family. And it is attributed to X-linked recessive gene. Unless there is a family history or a childhood inguinal hernia containing the testis, the condition is not diagnosed until puberty. The girl is typically feminine and tall. The pubic and axillary hair are scanty, but the breasts are developed because of estrogen derived from the peripheral conversion of androstenedione. The girl presents with primary amenorrhea, ovary and testes, uterus are absent. Ultrasound reveals absence of ovaries, uterus. Testosterone is present greater than 200 nanogram per ml. LH is raised, but FSH is normal. Chromosomal study reveals XY chromosome. Management. Once diagnosed, it is important to trace the location of the testis. Perform gonadectomy because testes are liable to undergo malignancy in 10 to 30% cases. Controversial point is when to perform the gonadectomy. It is preferred to remove the testis in puberty when the correct diagnosis is made at 16 to 18 years of age. These patients will require estrogen therapy for the development of breast and to prevent osteoporosis. If she plans to marry, vaginoplasty should be done. If sufficient length of vagina prevails, vaginal diuresis may be effective in stretching its length. Partial androgen insensitivity. Few receptors respond to the testosterone and the clinical features are variable. Some present at birth with ambiguous genitalia. Chromosomal study reveals XY chromosome. Others present at puberty with the lack of virilization in a boy or signs of virilization in a girl with primary amenorrhea. Treatment is based on the sex in which child is reared, psychological behavior, and the amount of virilization. If the child is reared as female, it is best to perform gonadectomy in childhood to avoid virilization. In boy, testosterone will help, but the reproductive function remains poor. Enzyme errors in androgen production. Production of testosterone from testes require enzyme, most important of which is 5-alpha reductase. That enzyme converts testosterone to dehydrotestosterone, which is capable of acting on peripheral target tissues to produce male phenotype. Absence of this enzyme results in female phenotype and male pseudohermaphroditism. Masculinization. Klinefelter syndrome is seen in 1 to 500 males. The patient with this rare disorder externally resembles a male in general body conformity. The penis is small or normal in size. The testes are small but as a rule are normally placed. Sterility is common. Gynecomastia is frequently present. The voice may be high pitched. Appearance may be unichoid. The patient is often mentally defective or delinquent. Most of these individuals are sex chromatin positive like females because of the extra X chromosome 47XXY. Testicular biopsy reveals hyaline degeneration of seminiferous tubule, overgrowth of the Leydig cells, as a result of which sterility is often presenting symptom. Sole to pubic length is more than normal. Person should be bred as male and should not be told about chromosomal abnormality. Testosterone may help. The breast may need surgical excision. Virilism. It is characterized by hirsutism and some of the male appearance and atrophy of breast. The patients exhibiting virilism, the chromosomal and gonadal sex is female, and the accessory sex organs of Mullerian origin are also feminine, but the external genitalia resemble the male. Clinical features include the body conformity is largely male with good muscular development and broad shoulders. The voice is deep and the thyroid cartilage is prominent. Hirsutism is present to a remarkable degree with male distribution of height. The psychological sex is often but not invariably male. The external genitalia show hypertrophy of clitoris and fusion of labia majora due to the failure of the cloacal membrane to divide in a congenital variety. The vagina is often absent if the cause is congenital. The breasts are underdeveloped. Other signs are frontal, temporal, vertex baldness, hoarseness of voice, diminished size of breasts, hirsutism, clitoral enlargement, acne, and amenorrhea. Adrenal tumor, male hormone secreting ovarian tumor are responsible for the virilism. Clinical varieties are adrenogenital syndrome. It occurs due to hyperplasia of the adrenal cortex and is of two types. This condition is also known as congenital adrenal hyperplasia, congenital or intrauterine adrenal genital syndrome. It is the condition in which the primary defect is a block in the conversion of progesterone to deoxycorticosterone due to enzyme failure of 21 hydroxylase. The normal adrenal cortex produces 3 C21 compounds. One is hydrocortisone and the other are corticosterone and aldosterone, and in addition certain androgen C19 compounds. The production of 17 hydroxyprogesterone, which is mildly androgenic in action, is controlled by adrenocorticotropic hormone or ACTH, and this in turn is controlled by the reciprocal action of the hydrocortisone. If therefore the hydrocortisone ACTH interaction is upset by a deficiency of hydrocortisone, the pituitary gland produces an excess of ACTH, which is in turn leads to adrenal cortical hyperplasia and excess output of androgen, notably 17 hydroxyprogesterone. The main androgenic activity of 17 hydroxyprogesterone is due to its conversion to D4-androstenedione, hence the other orthodox androgen. These androgens are responsible for the phallus, a female pseudohermaphrodite showing hypertrophy, the masculine appearance of the glans, persistent fusion of labia majora to resemble a scrotum. The miniature vagina opens into urogenital sinus. External appearance is that of male with hypospadias. The diagnostic feature is a very high value of 17 ketosteroid, 17 hydroxyprogesterone excreted. As expected, the chromosome pattern is XX in these girls. Electrolytes should be monitored as there is possibility of hyperkalemia and hyponatremia. Ultrasound shows ovarian and adrenal tumors in some cases. The treatment of this condition consists administration of cortisone, hydrocortisone, or the newer synthetic corticosteroids such as prednisone 2.5 mg twice daily in an adequate maintenance dose for adult and will restore the output of 17 ketosteroids to normal. The continuous use of these drugs carry certain dangers of adrenal deficiency due to suppression of ACTH, and this especially operates at the time of stress, such as when a patient needs an anesthetic. At these times, corticosterone coverage should be given to tide over period of stress, i.e. 1 day before, on the day of operation, and for 3 days after the operation. Dose of cortisone is 0.15 mg per kg in 4 divided doses for a child. In a child with salt losing condition, fludrocortisone 50 to 100 mcg daily with intravenous saline is recommended. The vulval abnormality is corrected by a small plastic operation, and as a rule, it is wise to amputate the hypertrophied clitoris between 5 and 10 years of age. Clitoroplasty with conversion of glands is preferred to amputation. Fusion of labial folds should be corrected in puberty. Menarche is often delayed and fertility is reduced in these girls. Cases of virilization of fetus in utero have been reported following the use of progesterone in the pregnant mother. In fact, all synthetic progesterone except 17-hydroxyprogesterone have some degree of androgenic effect. If progesterone is to be used in pregnant women, it should be devoid of any androgenic side effect. Postnatal androgenital syndrome. This may be due to excessive output of ACTH from a basophil adenoma of the anterior pituitary gland or the Cushing syndrome, which gives rise to adrenal cortical hyperplasia. An adrenal tumor that can be benign or malignant has the same effect. Adrenal tumor is not dependent on the influence of pituitary gland. In an undiagnosed case, initial accelerated skeletal maturation is followed by early epiphyseal fusure and stunted height. Precocious puberty, increased libido with aggressive behavior is reported in a few cases. Sterility is common. Cortisol therapy can avoid the undesirable side effects. Males with this syndrome also present with the features virilizing tumors and other conditions of the ovary, such as erinoblastoma, highless cell tumor, polycystic ovary, hypertrichosis are causes of virilism, produce a clinical picture somewhat similar to postnatal androgenital syndrome and are due to excess of testosterone secreted by the ovary. In the postnatal variety of virilism, the genital tract is normal, but the clitoris enlarges, uterus atrophies, result in amenorrhea, voice deepens, hirsutism is marked, breasts are atrophied. Secretion of 17-ketosteroid is raised only if adrenal is hyperplastic or neoplastic, whereas with a virilizing ovarian tumor, it is unaltered. Treatment of female pseudohermaphroditism. If the fault is an enzyme block at the level of 17-hydroprogesterone, the administration of cortisone or synthetic corticosteroid will efficiently control the excessive production of ACTH. If virilization is due to a tumor, surgical removal is needed. This applies also to the ovarian androgenic tumors. A regular maintenance dose of estrogen is usually effective in restoring some of the secondary sexual characters like breast development. Additional intermittent progesterone therapy prevents breast and uterine malignancy. The most effective treatment of facial hirsutism is shaving and cosmetics. Investigation and management of the intersexual patient. Genetic, chromosomal, and nuclear sexing. It is simple and reliable from the study of buccal smear, skin biopsy, or neutrophil examination. The external genitalia should be examined, preferably under anesthesia, when, for example, a vagina may be discovered concealed by the fusion of labia majora. Contrast radiography sometimes may be helpful. MRI is mostly helpful in these cases. Gonadal biopsy of testes in an apparent male. Laparotomy or laparoscopic directed gonadal biopsy in an apparent female provides an opportunity for examination of internal genitalia. The presence of rudimentary or underdeveloped Mullerian structures strongly suggests female sex. It is important to note that during laparoscopic biopsy of streak gonad, the ureter is in close proximity is also vulnerable to the injury. Ultrasound is alternative to laparoscopy. It may also throw light on some accompanying Wolffian anomalies. Estimation of estrogen, 7-ketosteroid, testosterone, 7-hydroxyprogesterone in the serum, urine may be done. DHEA level greater than 700 mcg per dl, total testosterone greater than 200 mcg per dl is abnormal. Estimation of serum electrolytes. IV pyelogram to detect any coexisting renal anomalies, MRI for suspected adrenal neoplasm, radiography of the pituitary fossa and the skeleton. Psychological assessment of the patient's sexuality is done. Hirsutism. It is defined as the presence of coarse hair in the female at sites normally present in males, i.e., upper lip, chest, chin, lower abdomen, and thighs. Hirsutism may or may not be associated with menstrual disturbances such as oligomenorrhea and amenorrhea. Virilization refers to condition of hirsutism associated with other male characteristics such as temporal baldness, hoarse voice, clitoromegaly, and muscle enlargement, as well as defeminization such as amenorrhea and breast atrophy. Endocrinology. In a woman, androgens are secreted by the ovaries and the adrenal glands in varying proportion. To some extent, they are produced by the ovarian peripheral conversion of androstenedione in the fat. The androgen produced are 25% comes from the adrenal glands, 25% from the ovaries. Rest are peripheral conversion of androstenedione. Testosterone 0.2 to 0.3 mg daily. 50% comes from the ovaries, remaining from the adrenal glands. DHEA 20 mcg daily and the rest from the adrenal glands. Androstenedione 3 mg daily. Dehydroepiandrosterone sulfate DHEAS 0.5 to 2.8 mcg per ml. Higher levels suggest the possibility of CAH, congenital adrenal hyperplasia. 17-hydroxyprogesterone greater than 800 nanogram per dl is present in CAH. Testosterone is bound to serum hormone binding globulin SHBG. It is produced in the liver, is inhibited by the androgen and increased by estrogen and thyroid hormone. Low estrogen and thyroid hormone cause fall in SHBG level. This results in some testosterone being released into the blood circulation as free testosterone, which can cause hirsutism. Similarly, obesity causes fall in SHBG as well as more peripheral conversion of androstenedione to testosterone. Ferryman Galway described a scoring system for hirsutism in 9 body areas on scale of 0 to 4 and quantified hair growth. A score greater than 8 is labeled as hirsutism. Causes of hirsutism are genetic and ethnic, excess androgen and increased sensitivity of pilosebaceous unit to the testosterone. Liver disease when SHBG levels drop. Ovarian, PCOD, hypertrichosis, masculinizing ovarian tumors like erinoblastoma, Hyler cell tumor. Adrenal, congenital adrenal hyperplasia, Cushing syndrome and adrenal tumor. Drugs like androgen, progestogen with androgenic effect, 9-nor steroids, levonorgestrel, anabolic steroid phenytoin, danazole, minoxidil. Others like obesity, hypothyroidism, anovulatory hypoestrogenism, idiopathic in 15% cases, hyperprolactinemia. Hirsutism occurs early in congenital adrenal hyperplasia, around puberty in PCOD, and in elderly women at menopause. Idiopathic, increased sensitivity of the end organ to 5-alpha reductase. PCOD accounts for 80% cases of hirsutism and is characterized by oligomenorrhea, obesity, hirsutism, and often infertility. Both ovaries are enlarged and covered with a thick, smooth, fibrotic, pearly white capsule. Multiple small cysts, 2 to 9 mm in size, are present at the periphery of the ovary, and the ovarian stroma is increased due to thicker cell hyperplasia. Ultrasound reveals ovarian morphology clearly, and diagnosis can be accurately established. LH level is raised even in the pre-ovulatory phase of the menstrual cycle, causing a high LH-FSH ratio, more than 1. This results in anovulation, high estrogen level, but the absence of progesterone. About 50% of women with PCOD will show raised levels of androgen, testosterone, androstenedione, and DHEA. Testosterone level, although raised, remains below 200 nanogram per deciliter, unlike that in ovarian tumor. Masculizing ovarian tumors cause defeminization such as breast atrophy, amenorrhea, beside hirsutism, hoarseness of voice, muscular development. Clinical examination may not always detect small tumor. Laparoscopy, ultrasound, and MRI may be required to locate the tumor. Testosterone level is raised above 200 nanogram per deciliter. Removal of the tumor restores the menstrual cycle, but hoarseness of voice, existing hirsutism, may require appropriate management. Congenital adrenal hyperplasia is diagnosed and treated before puberty. It is due to deficiency of enzyme 21 hydroxylase. 17 hydroxyprogesterone plasma level is more than 8 nanogram per ml. Cortisol deficiency occurs at times of stress. To diagnose, dexamethasone suppression test is done by giving 1 mg dexamethasone at night and studying a single plasma cortisol level in the morning. The level should be less than 130 nanomole per liter or 100 mcg. This test has a low false positive finding. CTA of abdomen and pituitary fossa may be required. Cushing syndrome occurs due to overproduction of ACTH by pituitary gland and adrenal tumor. Diagnosis is established by dexamethasone suppression test, ACTH level estimation, CT of the pituitary adrenal. Hyperprolactinemia may be due to enlargement of the pituitary gland or due to pituitary tumor, prolactin levels exceeding 100 nanogram per ml. MRI will help in diagnosis of mild prolactinemia. Also occurs in PCOD. Investigation include proper history taking, examination of the external genitalia, hormonal study include levels of testosterone, DHEA, androstenedione level, thyroid hormone level. Pre-ovulatory LH, FSH level need to be estimated. In PCOD, LH level exceeds 10 international units per liter. Testosterone is greater than 2.5 nanomole per liter. SHBG less than 30 nanomole per liter. Testosterone level greater than 6 nanomole per liter is in ovarian tumor hypertrichosis. Normal prolactin level is up to 25 nanogram per ml. Cortisol level should be less than 100 mcg per ml. In adrenal tumor, DHEAS levels are raised greater than 700 to 800 mcg per deciliter. It is a better estimate than 24-hour urine estimation of the 17 ketosteroid. 17 alpha hydroxyprogesterone greater than 800 nanogram per deciliter is seen in CAH. Plasma testosterone greater than 200 nanogram per deciliter is seen in ovarian and adrenal tumors. Ultrasound may detect ovarian tumor, PCOD, adrenal tumor. Management. Treat the cause. Removal of ovarian and adrenal tumor will stop further hirsutism. Metformin 500 mcg TID for 8 weeks reduces hyperinsulinemia seen in PCOD. Drugs like dexamethasone 0.25 mg to 5 mg daily at night will control adrenal hyperplasia if DHEA is raised. Combined OC pill may be needed in addition to dexamethasone to suppress the androgen. Anti-androgen used as spironolactone, cyprocerone acetate. Spironolactone in a dose of 100 to 200 mg daily blocks the androgen receptor, reduces the production and increases its metabolism, thus prevents hirsutism in further 60% of the cases. Side effects are transient diuresis, menstrual irregularity, breast development. Occasionally hyperkalemia, hyponatremia may occur. Maintenance dose after 6 to 12 months is 50 mg spironolactone with OC pills. Drospirenol 3 mg and 30 mcg estradiol used especially for 3 weeks are found very effective in hirsutism and PCOD. Cyproterone acetate is a potent progestogen with anti-androgenic activity, a synthetic derivative of 11 alpha hydroxyprogesterone. It inhibits DHT binding to its receptors at the periphery and has a weak corticosteroid effect. It is given combined with estrogen as 50 to 100 mg cyproterone daily for the first 10 days of menstrual cycle with 30 to 50 mcg of ethinyl estradiol for 21 days. After 6 to 12 months, a maintenance dose of 5 to 10 mg cyproterone acetate with EE will be effective in preventing recurrence of hirsutism. The effect becomes apparent after 4 months of treatment. Oral contraceptives regularize the cycle and prevent pregnancy. Estrogen present in the pills avoid menopausal symptoms, also raises the serum hormone binding capacity, which binds the free androgen and reduces insulin-like factor. Weight reduction will increase SHBG levels, binds free testosterone, thus reducing its peripheral action on hair follicles. Cosmetics. Bleaching, waxing, shaving, laser are helpful in removal of facial hair. Newer drugs are flutamide, non-steroidal, 250 mg BD for 3 weeks cyclically with oral contraceptives for 6 months, blocks the androgen effect at the receptor level. Finasteride 5 mg daily for 6 months blocks the conversion of testosterone to potent androgen and is safer than flutamide. It reduces conversion of testosterone to DHT. Dutasteride, Avodat, 5-alpha reductase inhibitor is under the trail. Summary of the causes and management of hirsutism. If the cause is ovarian androgens, androgen producing tumors like Sertoli Leydig cell tumor, hilar cell tumors, PCOD, luteum of pregnancy, theca lutein cysts, rapid progression, high testosterone level, pelvic mass may be present in the scanning, clitoromegaly. Treatment includes surgical excision of functioning tumor. In PCOD, mild elevation of testosterone, elevated LH-FSH ratio, and ovulation, infertility, irregular menstruation, and obesity. Treatment is OC pills, anti-androgen, weight control, metformin, lifestyle modification, laparoscopic ovarian drilling, ART procedures. Luteum of pregnancy. Onset is during pregnancy and conservative management is done. Adrenal androgen. Androgen producing tumor. It has rapid onset, high DHEAS, abdominal mass is present, clitoromegaly. Removal of tumor is a treatment. Congenital adrenal hyperplasia. Serum 17-dihydroxyprogesterone level are elevated. Glucocorticoid replacement and suppression therapy. Cushing syndrome. Elevated plasma cortisol. It depends on the cause. Exogenous androgens like hormonal drugs, methyl testosterone, anabolic steroid, and danazol. Withdrawal of the offending drug is sufficient. Hair follicle sensitivity. Excessive conversion of DHC in the hair follicle. It has a family history and of long duration. Racial trait. Spironolactone, ciprofloxacin acetate, flutamide, depilators, electrolysis, cosmetic treatment can be done. Exogenous causes of hypertrichosis are non-hormonal medications like phenytoin, diazoxide, minoxidil, streptomycin, penicillamine. Offending drug is withdrawn. Pathological states like hypothyroidism, anorexia, dermatomyositis, porphyria. Treating the cause is sufficient. Normal state like old age, ethnic trait, pregnancy. Observation and cosmetic therapy are done.